This presentation, Psychiatric Emergencies, What to Expect in the Emergency Department by Anisa Ralls, is brought to you by EvergreenHealth and NAMI Eastside.
I'll start by introducing myself. My name is Anisa Ralls, and I'm the lead emergency department social worker at EvergreenHealth. I've worked in the ED for over 11 years, and I have a master's degree in counseling from Seattle University, and I'm also a licensed mental health counselor. And prior to working in the emergency department, I was a therapist in an outpatient setting. So I wanted to say a little bit about my involvement in NAMI. I first found out about NAMI when I was living in another state and I was looking for support for myself for a family member. I attended support groups and I took the family to family class. And then when I moved to Seattle, I started going to grad school and I found NAMI Seattle and I worked in the office as their program manager. I coordinated the support groups, the family to family classes, and other educational programs. I was trained as a family to family teacher and eventually as a state trainer. And I wanted to share this because I know from firsthand experience how wonderful NAMI is as a resource for families and people with mental health concerns. And I believe in NAMI as an organization, and I still refer patients and their family members to NAMI for support and resources. So I was really honored when I was asked to speak at this forum to talk about psychiatric emergencies and what to expect if your loved one comes to the ED for help. I know it can be a scary experience because you're already in crisis, and when something is unknown and you're, that can just add to the anxiety of the situation. So I hope that we can, this presentation will be able to answer some questions and help people to understand the process a little bit better and hopefully result in decreased fear of the process. And so we are open to questions during the presentation, and we'll leave time at the end as well. And if you have any questions at any time, just like I said, I'll stop at different points and ask for questions and clarifications. And then there's also the chat too. So if you just want to put something in the chat, Ty will monitor the chat for us and let us know that there's a question in there. And then also, I just wanted to point out that this is really meant to just be a broad overview, and I'm not going to really be able to answer like specific questions about your specific situation. So just kind of keep that in mind when you ask your question. We might not be able to answer your specific question. And then I also have invited one of our emergency department nurses to help me with this presentation. His name is Rusty, and he's here just to add his perspective, a different perspective than mine. So I'll let him introduce himself now, and he can jump in whenever there's to answer questions and to add more information when I'm not able to.
Hi everyone, my name is Russell Genzel. I go by Rusty. Been a certified emergency nurse for 16 years. And I'd like to thank you for giving us this opportunity to speak with you.
All right. So I just wanted to start by giving a little overview and explain what emergency department social workers do and what our role is in the emergency department. We see a wide variety of patients. Obviously, if someone's coming to the emergency department, they're going to usually have some kind of crisis or emergency. Let's see. Here we go. Most of the patients that we see are seen for mental health reasons, and we complete mental health evaluations to determine if someone is safe to discharge from the emergency department. We can facilitate inpatient psychiatric hospitalization if that's determined to be the best plan, or can discharge patients home with the appropriate resources. We also see patients with substance abuse issues. This can be in addition to the mental health concerns, or it can be the primary issue. Patients will often come to the ED specifically because of their substance use, and they're interested in some kind of treatment, either outpatient or for detox. They can be referred to us due to concerns from the provider about their substance use. We complete a substance abuse evaluation and assist with getting patients into detox or discharge them home with resources. Mental health and substance abuse patients are the majority of the types of patients that we see. The other reasons we might have a patient referred to us would be for things like domestic violence, a sexual assault, elder abuse, child abuse concerns, assistance with senior placements, caregiving resources. We can also see patients for general resources such as shelters, assistance with paying for prescriptions, transportation assistance. If a patient is critically sick in the emergency room, we will provide assistance to the family and support them during the critical time of the patient's death. Really, we can see patients for any other issues that the doctors or nurses aren't really able to manage. So it's definitely not boring in the emergency room, and you never know what the day's going to bring. So that's the reason why I love working in the ED and being able to help people through the crisis that they're experiencing. So now I'm going to focus specifically on mental health patients and how we help them. So patients with mental health concerns come to the ED either voluntarily or involuntarily. Voluntarily patients are usually brought to the ED by a family member or a friend, or they can bring themselves. They are usually looking for some kind of help for mental health concerns such as depression, anxiety, mania, psychosis, suicidal thoughts, or an attempt. Sometimes patients present with these issues with other issues such as chest pain or a medical concern. And then once they're seen by the doctor, it's determined that the patient is really having psychiatric symptoms that may be causing or contributing to their somatic complaints. At that point, the provider would refer that patient to the ED social worker, and we would meet with the patient and assess them to determine the proper outcome. Some patients will not willingly come to the ED voluntarily, so they are brought to the ED involuntarily by police. This usually happens when a friend, neighbor, family member, community member calls 911, and the police responds to the patient and determine that they're not safe to be left alone and place them on what's called a police hold. They are sent to the ED by an ambulance, usually in restraints, until they get there. And then patients will also call 911 themselves asking for help, and the police will respond to them and send them to the ED involuntarily. So once the patient is on the police hold, they can't leave the ED until they're deemed safe by the MD, which is usually done once they've been evaluated by the social worker. A lot of these patients are intoxicated when they arrive, and they've made some kind of suicidal statement or attempt. They might be under the influence of other substances and were doing something dangerous in the community that made the police concerned about leaving them there. So some examples might be a patient is intoxicated and texts their friend or their family member that they want to die, or they're like saying goodbye in the text. And then that person would be concerned and call the police, called 911, and then the police would respond to their location and then most likely have them sent to the ED involuntarily. Another example would be that the patient is at home with a parent or another family member, and they're having some kind of psychotic episode and becomes physically assaultive. And then the family calls 911 out of fear. And the police will respond and determine the patient's not safe, and will have them sent to the ED involuntarily. So those are just kind of a few of like the most common situations, I think, that why patients would get there. So I'll stop now and see, does that make sense? Do you have any questions about that? Do you need some more examples?
And once again, you're welcome to ask questions either by coming up on microphone if you're fine being caught in the recording, or by asking them in text chat if that's either your preferred method or if you want to remain anonymous in the long run.
And if you have anything to add, Rusty, too.
That was a great summary.
We have a question in text chat. Are you saying that the initial evaluation is done by a social worker?
So we'll get into the process and what the evaluation is done, but yeah, they're seen by the doctor and by a social worker. Okay. All right. Well, feel free to, if you think of something, you can always just add it into the text as I'm talking, and then we'll stop at different times. Okay. So I'll move on. Okay, so now I wanted to talk about what the process is of getting the mental health evaluation once the patient is in the ED. So the process is usually that they're just brought back to the exam room, either from the triage area or brought in by the ambulance and from the gurney and to the bed. They're given specific scrubs with snaps and not ties due to ligature risk, and then they're asked to change into them. All their belongings that they came in with are removed and they're locked up in a locker. And the reason for this is because we have to keep the patients safe. Sometimes they come in with things that can be dangerous, such as weapons or substances. Also, when patients have their phones, it can cause issues. In the past, we've had issues with patients posting things on social media or even calling the police while they're there in the ER, or they might contact the person who they were in an argument with prior to coming in, or the person who called 911 and had them brought to the emergency room. So then that can make them more upset and cause problems. So the ultimate goal is always to protect the patient and keep them calm in a very stressful situation. And obviously this can be difficult to expect patients to just change their clothing and give up their belongings when they're already in a crisis. And we recognize how difficult this can be for patients. And we talk to them, we explain everything, we give them time to be able to do this. And then if for some reason a patient's not safe to be removed from the restraints when they arrive, they might need to stay in restraints until they can demonstrate that they can be calm and they won't be assaultive or combative or try to leave. We can also use things such as medication to help calm a patient down, and also have locked seclusion rooms as well. We always try to use the least invasive intervention as possible to manage a patient in a safe manner. And then if they have someone with them that comes in with them, I think we're allowing one visitor now. Things changed with COVID, but I think we're back to allowing one visitor now. But we'll only allow that visitor if the patient's behavior is cooperative and that person is not further upsetting them. And then all of the visitors have to lock up their belongings in a locker too. If the visitor is not able to come back to the patient's room for some reason, but they have information that they want to share with the ED staff, then the provider, the nurse, or the social worker can speak to that person separately. And that person could leave, and then we can call them and gather the information later by phone. Sometimes it's best if the person is left alone during this process, which I know can be really difficult for family members or loved ones to understand sometimes. But each situation is different, and we try to do what's best for that patient depending on what's going on with them. And we try to communicate that with, the family member or the friend or whoever brought that in too. So once the patient is changed and they're safely in the room, the nurse will triage them and the doctor will gather the initial information together. They also are watched by a sitter on a camera the whole time they're in the emergency room. The nurse and the doctor aren't doing the full mental health information, but they're not doing the full mental health evaluation, but they're just gathering the initial basic information and focusing on like medical concerns that the patient might have or that they might need to be aware of. The MD will order the appropriate medical testing, which will generally requires the patient provides a urine and a blood sample. Once all the appropriate labs are completed and the patient is medically cleared, then they can be seen by the ED social worker for the full mental health evaluation. The whole process can vary depending on the situation. If a patient is not intoxicated and has not had does not have any major medical issues and is calm and cooperative and able to provide urine and blood for labs quickly, then they can be medically cleared pretty fast. If any of these things are not true, there's an issue with any of this, then that would lead to a delay. So for example, if a patient is intoxicated and their blood alcohol level is over 0.08 or 80, which is the legal limit, then we would have to wait until they're sober to complete the evaluation. So, typically we think, patients metabolize alcohol like 25 points an hour. So, if you think if somebody comes in with an alcohol level of like 300, then they might have to come down 220 points, which could take like 9 hours. Like that's a really long time, so that could lead obviously to a big delay. So it could be quite some time before they're deemed medically cleared for the social work evaluation. Also, if they had an overdose on some medication and it's not serious enough for them to be medically admitted to the hospital, it can take several hours for a patient to be medically cleared and the effects of the medication to wear off. Some patients are also under the influence of methamphetamines. Sometimes those patients come to the ED and then they sleep for a really long time. Once they wake up, the effects of the substance have cleared and their behavior is no longer dangerous. We see that a lot too, where they come in and they might have been using meth. That's why they were brought in, and then they sleep for a really long time and they wake up and then their behavior has really improved, and it was really just the effects of the meth that they were using. So it's really important for us to take into consideration all of these factors before we complete the mental health evaluation to ensure we're doing a thorough and accurate evaluation. Like you wouldn't want to just jump in and do the evaluation like right when they first get there. Like we have to go through this process and it can take a while. So then once the patient is medically cleared, the ED social worker will meet with the patient and complete the mental health evaluation. We take time to talk to people that have firsthand knowledge of the patient's behavior and the concerns that they have. We also call the county crisis line, who can tell us if the patient has been involved in the public mental health system and if they're currently receiving services. They can tell us their hospitalization history and if they went to hospital voluntarily or were involuntarily detained, if they're currently tiered or enrolled in a public mental health agency and receiving services like Sound, for example. Sound is an agency that a lot of people go to. Then we would reach out to their case manager and find out if they're engaging with treatment and what kind of concerns that they might have. A lot of the patients we see in the ED have been seen before, and so we can look back in the electronic chart and see if they've been evaluated by the social worker in the past. So I always try to read the previous evaluations and learn as much as I can about the patient before I go in to do my evaluation. It's helpful to, this just helps me to understand their history and what the previous outcomes have been. And it's helpful to reach out to other people who are involved in the patient's life too, to make sure you're getting a more complete picture of the patient and the situation. And then when we complete the mental health evaluation, we're doing a fairly in-depth assessment of the patient. We're finding out specifics about what situation brought them into the ED this time, and what were the stressors and the precipitating events. We ask about their current functioning. We're really trying to focus on like the last 2 weeks and what's changed with their mood, appetite, sleep, their weight, energy level, self-care, work, school functioning. So we're trying to determine if the patient is at their baseline or if there's been a change and how that's impacting them. We assess for psychotic symptoms, what their substance use is, current and past, and we ask about their past psychiatric history and assess the current mental status. Finally, we assess the patient's current suicidal and homicidal thoughts and plans. We're really trying to determine if the patient is safe to be discharged from the hospital and take into account their current treatment, compliance, support, and insight into their symptoms. This is why it's important to talk to other people involved in the patient's care, because not all patients are completely forthcoming about their functioning and current symptoms, either because they lack the insight or they might want to present as doing better than they actually are. So once we've completed the evaluation, then we determine what the best plan would be for the patient. We discuss this with the treatment team, including the nurse that's involved in their care and the doctor. And then if they have any outside providers. And we also take into account what the family members or friends are recommending for the patient as well. So does anybody have any questions about that? Or Rusty, do you want to add anything about that whole process when they first come in?
The one thing I would add is in some of those cases where we're waiting for a long medical clearance, we're all doing our best to try to keep everyone comfortable, fed, informed, and anything we can do to lessen the stress of that wait.
Yeah, sometimes that can be the hardest part, is the waiting. Okay, well, hopefully all of that made sense, but please let me know if you have any questions about any of that part of it. Okay. So we'll talk about what some of the possible outcomes might be for the plan after we do the mental health evaluation, depending on the situation. So we're always looking for the least restrictive option for a patient. So first, I would say the patient could be deemed to be safe to discharge home, and we would do safety planning and arrange follow-up treatment for the patient. So this is where it's really important for us to connect with someone who knows the patient to determine who can support them and help them as needed. We would talk about things like removing access to means that the patient could use to harm themselves and provide extra support. If they have a provider, we can schedule a follow-up appointment for them to see their provider. If they don't have a provider, we can help schedule an appointment for them or give them information about scheduling an appointment. And then there's also partial hospitalization. That can also be an option for more intense short-term therapy during the daytime, but this generally requires private insurance. So that's kind of a nice step between hospitalization and sending someone home just for outpatient treatment, because they could go every day to the hospital. Like it's like Monday through Friday, like I think like 9 to 2 or something like that. And it's a structured program where they're going during the daytime. They're getting groups and, you know, pretty much the same treatment that they would get in the hospital, but they're safe to go home at night. So they don't need that highest level of hospitalization. So then if the patient is not, it's determined they're not safe to be discharged home, or maybe they're homeless and they don't have support, but they don't really need inpatient psychiatric hospitalization, then we could have them admitted to something that's called a crisis bed. The place in King County that we use is in Seattle, and it's run by DESC, and it's called the Crisis Solution Center. And this is a short-term stabilization facility. It's less structured than an inpatient hospital. Typically, it's for patients who need more support than a shelter, but really don't need hospitalization. They can stay there for a few days, and they have 24-hour mental health professionals that are there. It's they have semi-private cubicles, and it's a co-ed facility. But they can also leave to take them to appointments, like if they have appointments in the community. So it's a nice option for people. Okay, and then the next step would be if it's deemed the patient's not safe to discharge home and they require inpatient psychiatric hospitalization, then the patient could be admitted to the hospital either voluntarily or involuntarily. So if the patient is agreeable and is willing to go voluntarily, then we'll start the process of trying to have them hospitalized. We'll call around to the area psychiatric hospitals until we find a bed. Once we find a bed, then we start the screening process. And this involves faxing the patient's chart and including all of the labs and the social work evaluation and everything to the intake team. And then they review it, and then they will seek acceptance from their medical provider. And then if the patient is accepted, then that hospital tells us what time the patient can arrive, and then we arrange for the ambulance for the patient to be safely transported there. And this is deemed medically necessary due to the situation, and it's covered by insurance. If the patient is not accepted by the hospital when we screen them, then we try to determine why they are declined. Like, is there sometimes, maybe they have concerns about like a certain lab or something like that. Maybe there's a medical concern or something that the psychiatric hospital is concerned about, or maybe there's some behavioral concern that they're concerned about. So we try to figure out what it is, and then we try to address it. So hopefully they'll reconsider and we can get them accepted. But if they won't reconsider, then we move on and we try to find another hospital, and we keep calling until we can find a hospital to accept the patient. So this process can take a while. It can take several hours or even several days, depending on availability and what the specific issues are to consider. So if the patient isn't willing to be admitted voluntarily, or it's determined that the patient is not able to consent to voluntary hospitalization, then we would refer them to the designated crisis responders, the DCRs, and that is through King County Crisis. So the ED social worker makes the referral, and we write a statement called an affidavit, and then the DCR comes to the ED to assess the patient. The DCR makes the final decision on whether or not the patient meets the legal criteria to be involuntarily detained. If the patient is not detained, then they would likely be discharged from the hospital. Sometimes the DCR determines the patient is agreeing to be a voluntary patient, and that maybe they might be a good candidate to go to the Crisis Solution Center, the CSC. So then we would work on that plan. But if the patient is detained, then the DCR will let us know if there's a bed available. There are only certain hospitals who accept detained patients, and oftentimes they're full. If the patient is accepted by the hospital, then they will be transported there. They are detained initially for 120 hours, excluding weekends and holidays. Then they have ITA court to determine if they need to be treated longer or if they are safe to be released. If there are no beds in the community, the patient will wait in the ED until there's a bed available and the patient can be transferred. At this time, they'll be seen by a psychiatrist in the ED once a day to manage the medications, but this is really only for the detained patients. They would see a psychiatrist. So that's kind of a really, I guess, broad overview of the DCR process. We could probably spend a whole talk just specifically about that, but I was just trying to give you an idea of what the different types of options would be once we do the assessment, and what, where we could refer patients.
We do have a question in text chat. What if the patient is adamant that they are fine and is calm and not agitated once they get to the ED, but a family member tells their version of what led them to come to the ED, and the patient really is not or was not fine, and the patient isn't even willing to be evaluated?
Yeah, it gets tricky, definitely. That's why we try to talk to family members. And like I said, we try to look at the whole situation, and we try to figure out what the concerns are. And if a patient really won't even be evaluated, then that to me shows some concerns, because I understand we've had lots of situations where people getting into an argument, maybe, they're in the heat of the moment, they say things that they regret, like, fine, I'm just going to go kill myself or something like that. And then the other person calls the police, and then they bring them to the emergency room, and, we do the evaluation, and, we understand, like, okay, let's talk over what happened. I understand it was a stressful situation for everybody involved. We try to hear both sides of everything. And, we're looking at the whole picture and their presentation and their history and all of that information. We're taking all that into account. And, we understand that sometimes things get blown out of proportion, and in the heat of the moment that things happen. And that doesn't mean that we're going to hold you there against your will and force you into a psychiatric hospital because of one thing that you said. So yeah, I think it can be very tricky when we're hearing, the patient is presenting as one way to us, but the family is telling us a whole other story. And, sometimes we might have to have the designated crisis responder come in to do an evaluation, and because the family is really adamant that no, they are not safe to discharge home. They are really dangerous. I have all of these examples that I can give you. And even if we're not seeing that, sometimes it helps to have the DCR come in to help to do their assessment and to determine if they really do need to be in the hospital or not. What would you say about that, Rusty, in those situations?
Yeah, and it kind of depends too on who brings them in. If they're, there's a whole process. If the police bring somebody in, they kind of have to participate with us. If they bring themselves in voluntarily, that's when it gets really tricky. Is technically if Anisa's group is evaluated, we've all looked at you and you seem fine, family's telling us something different, you might direct the family to call the police or somebody else to establish that, because at that acute point in time, we can't really hold people, like Anisa was saying.
We've got another question. If a patient is waiting for days in the ED for a bed, is there a doctor overseeing their care?
Yes, we always have a doctor that's there in the emergency room. Mhm.
And they're getting their regular meals from the cafeteria, just like any patient in our hospital would be getting that would be there for days. We're giving them their medications, because oftentimes people have medical problems as well, like high blood pressure or diabetes. So we're still helping people continue their care while they're doing that wait and trying to keep them as comfortable as possible.
Right. Yeah, it's definitely not the ideal situation. We are trying our best to get people out as quickly as possible. But unfortunately, with just the beds in the community, in the situation, there's just sometimes there's just not enough beds for people who are in need. And so unfortunately, they do wait in the emergency room for a while. Okay. So I will move on and let us know if you have any questions about anything else. Okay. So I wanted to share a little bit about some tips for family members. Some things for family members to know if a family member of a patient there is that you might not be able to be with the patient the whole time during the ED for the whole time they're in the ED for various reasons. Some of those things I already kind of went over, but hopefully that makes sense and you understand that. Also, we might not be able to share everything with you due to HIPAA constraints. If the patient is in the ED voluntarily and doesn't give us permission to share information, then we might not be able to. If the patient is in the ED involuntarily and does not want us to share information, but you were the one involved in the situation that had them brought there, then we might be able to share more information. It depends on the situation. Also, we might not be able to give multiple updates throughout the ED visit. So if we have your contact information, we'll be sure to update you when we have something to update you on. Sometimes it's just a waiting game and we're waiting to hear back from a hospital or waiting for the DCR arrive. So sometimes there's just like this long waiting, and then, so that may be why you're just not hearing from us. Like if you want an update, and I know that can be really hard if your family members then been there for like a day and you haven't heard anything. But sometimes it's just there's really no update. There's nothing for us to share. Another helpful thing is to know that it's really best if we just have like one main family member or friend who's designated as the point of contact, because it can be difficult for the social worker or the nurse to have multiple people calling in for updates or try to find out what's going on with the patient. And sometimes we don't know if it's okay to talk to all of these different people that are calling us, because, sometimes it might be okay to talk to mom, but not to dad. And then, the next social worker comes on shift, and then, then we've got a different family member calling us. So it just can get a little bit confusing for us sometimes. And we can't really even verify if the person who's calling us is really who they say they are. So if we're hesitant to give you information, just know that it's because we're trying to protect our patient, and we might not be able to give you the information that you're asking for. Another issue is that the ED is extremely busy, and there's usually only one social worker working each shift. Sometimes we have more, we can get a backup social worker, but sometimes there's just one social worker. And so if there's multiple patients to be seen, and we're spending, each evaluation can take a really long time. It can take, a couple hours to be with each patient. So, if I'm spending several hours with each patient, that can mean the other patients are waiting to see the social worker. Unfortunately, it's just like this in all emergency departments. It's not just in Evergreen. That's just the way of the of emergency departments now. So if you bring a patient to the ED, just know that you might need to be prepared to wait for a while. Other barriers that could cause long waits could be things like if, let's see, I think I have another slide for this. Okay, so these are some barriers to placement. So if the patient has medical issues or substance abuse issues, that can make finding placement difficult. Sometimes, if the patient is a teen or an elderly patient, so adolescents or geriatric patients, those patients with dementia are really difficult to place. These patients usually end up waiting in the hospital for several days for a bed. If the patient has dementia and they need, specifically, they need to go to a geropsych facility, then they usually will probably have to be involuntarily detained. And Northwest Hospital is really the only hospital that has a geropsych hospital that can take involuntarily detained patients. And so that's the only hospital that they can be admitted to. And that wait is very long. It can be several weeks or even a month to get into that hospital. So sometimes those patients end up getting admitted to our medical floors instead of keeping them in the emergency department for weeks or, really long time. So those are kind of the biggest ones. And then there's also just, bed availability is probably the biggest one. It's just that, there's no beds available for patients. So they just end up waiting a long time. There's probably a lot of other examples that I could give, but those are the main ones that I can really think of. I don't know, Rusty, can you think of anything else that's like a major, that we see that are like major barriers or delays in the emergency room?
No, that's a great summary. I can't think of any other ones.
We do have a question in text chat. Do you have any recommendations for someone who needs mental health treatment for schizophrenia, but does not want to go through the emergency room and is not currently suicidal?
Yeah, if they want mental health treatment, there's definitely outpatient options for them. So it really depends on, I know NAMI is really good about connecting people to resources. You can also call like 211 to get that information, but there's lots of agencies that accept people who have the Apple Health, the Medicaid, like Sound. It depends on where you live, and it depends on your insurance, I would say. If you have private insurance, you could contact, look at your website of your insurance company, and you could get a list of a lot of different outpatient treatment options. But if you have Apple Health, then there's like specific agencies that you need to go to. So start with usually you start with like an intake. They schedule you for an intake, and a lot of those agencies have walk-in appointments too, like walk-in times. You can go at certain times and just walk in for an intake. So that would be the first step, is getting assessed, and then they would get you connected with a therapist and with a prescriber.
And then as a follow-up to that question, outpatient treatment must be voluntary, right?
Yes. So I would say the only time that it would be not completely voluntary is if you've been involuntarily detained and then the judge releases you from that hold, but you're on something called an LRO, a least restrictive order, which basically is saying you are mandated to outpatient treatment. And if you're not following the order, then you could be detained again easily and sent back to the hospital. The order would be revoked. But outpatient treatment, it's completely voluntarily, and nobody can force you to go to your appointments and to go to into outpatient treatment. Really, involuntary hospitalization is the only way that anybody could have treatment forced on them. And so that's why there's that very, strict criteria, the legal criteria to get people involuntarily detained.
Another question, are there enough mental health social workers to cover 24/7?
At our hospital, there is. In the emergency room, we have 24-hour social work. So we have somebody on the day shift. That's what I work. And then, so I work the 7 to 3, and then somebody comes on at 3 and works till 11. And then somebody comes on at 10:30 and works the night shift until 7 a.m. So we have 24-hour social work at Evergreen. And like I said, sometimes when we have more patients than what we can manage, then we can get a backup social worker to come and help too. But yeah, there is 24-hour social work, but not at all hospitals. I don't think every emergency room has 24-hour coverage. So we're lucky at Evergreen that we have that. I know that was a lot that I covered, so I hope that gave a good overview of what it would be like.
So we're now just in the open Q&A period of the presentation. So feel free to put any questions in the text chat, come up on mic if you don't mind being recorded, and just generally ask anything on your mind about the presentation. We've certainly got plenty of time on our hands, so don't feel like you're taking up a limited resource there.
Mm-hmm. If you have anything to share, Rusty, that you don't think I covered.
Do other hospitals have, I guess I'm thinking of major hospitals with emergency departments, have at least day mental health social workers, or are you very thin on the ground as far as other hospitals go? I mean, it's your, mental health social workers. Are they,
As far as I know, in this area, all of the all the EDs have a social worker during the daytime in the emergency room.
and if it was an involuntary, if the police brought in a patient involuntary, do they know which hospital to take them to? Do they know which hospitals have mental health social workers at which times?
Yeah, I think the police, I mean, my experience is the police know the hospitals pretty well in their area. And so they need to go to, in an emergency situation, you have to go to the closest emergency room. But they are going to go somewhere where it's appropriate, that they can manage that patient. Yeah.
And how long has that been the case? For example, how long has Evergreen had mental health social workers?
Really long.
24/7.
Well, I mean, I've been there over 11 years, and so and we've always had it. I know they had a period of time prior to me working there where they didn't have coverage from like 2 to 6 or something, like 2 a.m. to 6 a.m. They didn't have coverage, and when I first started, I worked nights, and it was, there were nights where maybe we didn't have any patients, like any psychiatric patients, and things have changed so much. Like now, every night we have patients. So we've gotten busier and more mental health patients, definitely. I feel like more complicated situations too. There's definitely been an increase. Yeah.
Okay, thank you.
Rusty, you've worked at other emergency departments. Do you know kind of what it's like? Is this typical of other places?
I know I worked at UW at the Motley campus, and they had 24/7. And then, of course, like Harborview, they do have 24/7. I think they even have psychiatrists there at nighttime because they have a special obs unit for some high acuity people. But I think that's pretty much expected. Like Anisa was saying, in the past, the volume just wasn't there, but now it's kind of to our advantage to have people with Anisa's expertise there 24/7, because it really propels the care of the patients and gets them to the right place much faster if they're available 24/7.
So can't say main problem, but is one of the big issues having a bed? It sounds like it's searching for a bed is one of the major issues that you have to deal with once it's been decided that the patient needs admittance.
Yeah, I would say lack of availability of beds is a big problem for us. Yeah.
And that's a problem across the country, not just in our area, just not enough mental health beds in the US. It's a common topic that's published about in our professional journals.
And like I said, especially the adolescent population and the elderly population. So those are really a big need. There's really not a lot of places for if you're under the age of 18 or if you have dementia and you need specialized treatment.
Okay.
All right, we have a question from text chat in 2 parts. The first is, do the regular doctors or a psychiatrist review an emergency room patient's psychiatric meds?
Well, I would say I think everything, all the answers I can say, it always depends on the situation. So if the patient is going to be assessed and they're going to be discharged home, the chances that the doctor would do anything different with their medication is very slim. We would just probably, send them home and say, follow up with your prescriber. But like if a patient is coming to the ER and expecting that their medications are going to be changed by the doctor or by a psychiatrist, that's likely not going to happen also. That's not what the doctors in the emergency room do. They're not really comfortable with changing people's medications or starting them on new medications. So they would be seen by a psychiatrist if they were involuntarily detained and they were waiting for a psychiatric bed. We have a psychiatrist that will come to the emergency room and see those patients. And so they could change their medications or they could start them on some new psychiatric medications.
And the second part of the question, and if they get admitted to the hospital unit or overflow area, is a psychiatrist involved with their meds then?
If they go upstairs for the medical, to the medical floor, they would be seen by a psychiatrist. Yes. Like I was saying, those the geropsych patients that are waiting for a long time, they're usually seen by the psychiatrist. Rusty, do you want to say anything about medications and how we manage medications in the emergency room?
Yeah, we it's kind of a collaboration. We're all trying to figure out why in that hold time. We do it through a variety of methods, like asking the patient. Sometimes they bring their meds to us. So if we're trying to maintain their current medications until they get to their next spot, we rely on that. And then there's a way we can, some pharmacies were able to see prescriptions that have been dispensed. So a combination of interviewing the patient family, the bottles, and seeing what's been dispensed. We tried to keep them on their regular meds while they're waiting for their next spot.
So would adolescents under the age of 18, would they, for example, go to children's or
so children
initially?
So children's is usually not an option for us because they take children of all ages under the age of 18. And so they're generally pretty full. They have a long wait list, and they prioritize people that are younger than 13.
Mm-hmm.
And so if I have an adolescent that's between the ages of 13 and 18, then I would generally try other hospitals before children's. So there's like Fairfax has an adolescent unit, Smoky Point in Marysville has an adolescent unit, Marybridge in Tacoma. That's pretty much it. There's a few other ones, but they're out further. You're talking in the other parts of the state. Those are kind of it. And so if they're full, then I can try children's, but you're basically just putting them on a wait list and then waiting for a bed to open up. But if you have an adolescent under the age of 13, then children's is our only option. There aren't other places that would take under the age of 13.
Okay. So just to follow up on that, you say that, that's a bed situation there also, and you're on a waiting list. So that applies regardless of how, not important, but I guess, well, I would say important.
Acute the situation is?
Yes, yes, that's right.
Yeah, with children's, they do like a intake with the social worker who's making the referral, and they take all that information, and so they are looking at acuity, and sometimes they'll come to us and they'll say, I don't think this person needs hospitalization. I think they need to work with their outpatient provider. They'll tell you if they think they don't meet our inpatient criteria. We need them to or maybe they've had multiple hospitalizations. We see that a lot where people cycle in and out of the hospital and they're not engaging in outpatient treatment. And so, you know, that might be another reason why a hospital might say this person really doesn't meet criteria for inpatient hospitalization, or we need them to try to connect with our outpatient provider and try to see what other alternatives they can come up with, and try to do more safety planning. Have you talked to the family about this situation? Can we try to mitigate these concerns, you know, before we just work on a hospitalization? Because hospitalization isn't necessarily always the best or the most appropriate response for every situation. And so that's why I was saying we always try to do what is the least restrictive option for the patient. So we don't just jump to hospitalization for everybody. Yeah. So yeah, children's does, they go through a whole like intake process with us when we make the referral, and so I think they do try to prioritize people that are more acute or and especially younger kiddos, who there really aren't any other options for.
Another question from text chat. What is the background of the social worker in the emergency room department? Do they have additional classes or experience in the psychiatric area?
Yes, so I am an LMHC, a licensed mental health counselor, but most social workers are MSWs, and they have their masters in social work. So they've been through school specifically for social work and have taken classes around psychiatric emergencies, mental health. And then we do, we have a license, and so we have additional CEUs, educational classes that we take every year. And so you can focus on different topics that you want to get more training in.
So I'm still thinking about the hospitals that don't have mental health social workers. Mm-hmm. Would they, if a patient is presented there, would they or might they refer them to someone that does have a mental health social worker if they think it's necessary?
Yeah, I think in this area, you're not going to run into that problem. Probably more in areas of the country that are more rural that might have an issue with finding coverage. But now with like telemedicine, telehealth, people are getting pretty creative. I know a lot of places are finding other ways. They're going to find a way to get that patient to get the help that they need. They wouldn't turn that person away, especially if they are in some kind of a crisis.
So, yeah, so I guess that's a plus for telehealth. Yes.
Yes. Oh, definitely. It's been expanded in the last year. And it's one of the good things that's come out of this last year is that we are able to help more people and access services. Mm-hmm. Yeah, I'm not sure what it's like in like rural parts of the country.
Yeah.
But I know in this area, they're not going to turn people away, and they're going to make sure that they're seen appropriately.
Another question from text chat. Evergreen does not have an inpatient psychiatric unit, right?
Correct. We do not have inpatient psychiatric treatment in our hospital, right? We do have an in-home mental health program, which is an outpatient mental health treatment program. It's for people who are homebound, and they would get tiered for to that agency, just like I was saying, like Sound, like one of those agencies, they would get, so they would have an assigned case manager and they come to your home. That is something that Evergreen does offer.
In that case, who would be the person that checks on the insurance in those particular cases? Would it be someone at the hospital, or
to connect people to outpatient treatment?
Hmm.
That is something that we do when we have patients and we're trying to connect them to the appropriate outpatient resources. If we're going to discharge them, that we take into account what their insurance is and where they live. So that's usually what I'm looking at is what type of insurance do you have? Where do you live? How can I connect you to the appropriate resources? So I know, I know who takes, what insurance. And like I said, if you have like private insurance, you can usually go on that insurance company's website and you can search for mental health providers and you can find them and then, contact them to set up appointments.
right? I guess that's I guess that's part of a social worker's work anyway. If someone can't do it for themselves and they don't have anyone, yeah, you would cover that anyway, I suppose.
Yeah, we would tell them.
Insurance, yeah.
Yeah, we would tell them how they could sign up. A lot of people can qualify for Medicaid and they don't even realize it. And so we can explain to them is, you can sign, because some people might think, well, I don't have insurance, I can't get mental health treatment. So that's something that we would talk to them about. Like, well, actually, you probably would qualify for state insurance for the Medicaid, Apple Health. So here's how, this is the process. And we also have outpatient social workers in the hospital that we can refer them to, and they can follow up with people and they can get them connected to those kinds of resources. And for insurance specifically, they can help them apply for programs. So I feel like we really do try to connect people to the appropriate resources and not just see them and say, okay, well, we're discharging you now. Like, we always spend the time to really work with them and the family to make sure that they have the follow-up treatment that they need. Yes, I understand. The system is really difficult to navigate, even if you're not in a mental health crisis. It's difficult to navigate.
Yes.
So anything that I can do as a social worker to try to help the family member or the patient out to really, give them the appropriate resources and make that a little bit easier to connect with them. That's really what I feel like my job is, what I try to do. Any other questions about anything that we covered? I guess I would just say that we just want you to know that if you know somebody or you yourself are having a hard time or in crisis and you're just not sure what to do or you don't feel safe, then that's what the emergency room is there for. We're there to help you, to help people in those kinds of situations. So I just want people to know that, that's why we're there. And we have social workers there for that specific reason.
So if you were in a case of, for example, domestic abuse, would that be something you could go to the ED with?
Yeah, we get patients that come for domestic violence situations. We can help them, obviously if they have any medical concerns, and then the social worker can meet with them and talk to them about their situation and help connect them to resources.
We have a number of thank yous in chat, but no more questions right now.
Okay. I hope it was helpful for people. It's hard to know if you've never been in that situation. And for us, I think, we're used to it every day. We see it every day. So it's not as, scary and confusing for us because we know what to expect. But if you've never been there, you don't know it. So
Thank you for watching. Thank you as well to Anisa Ralls for presenting and to EvergreenHealth for supporting this series of forums. If you want to attend future Evergreen forums, you can find the upcoming topics, dates, and registration links on our website at nami-eastside.org/forums.